Hello there, Bernie here, and welcome to the Cardiac Physiologist channel. If you're interested in an allied healthcare career working directly with patients and helping people to get better, you're in the right place. Grab a cup of coffee and let's explore the world of cardiac physiology. Today we will explore some amazing catheter-based techniques that are revolutionizing how we fix certain heart conditions without open heart surgery. There's a lot to cover, so let's dive right in. Our first procedure is transcatheter aortic valve replacement, also called TAVR. This treats aortic stenosis, which is when the aortic valve thickens and can't open properly. It used to require open heart surgery to replace the valve, but now we can thread a compressed artificial valve up through the femoral artery to the heart. Once in position, it's expanded with a balloon and replaces the diseased native valve. The old valve gets pushed to the side and the new one starts working right away. TAVR allows us to replace valves in patients too high risk for surgery. Now let's discuss repair procedures for leaky mitral valves causing regurgitation. The MitraClip system allows us to grasp the edges of the mitral leaflets with a catheter device and clip them together in the middle. This reduces the amount of regurgitation through that area. Though it rarely eliminates leakage completely, taking a patient from severe to moderate or mild regurgitation can significantly improve their symptoms. Relatedly, we have some exciting transcatheter mitral valve replacement technologies in development, like Tiara and Intrepid. These allow an artificial valve to be implanted via a minimally invasive transapical approach. Clinical trials are ongoing, so we expect growth in these minimally invasive options for treating diseased mitral valves in the coming years. Tricuspid regurgitation is another condition we're tackling with transcatheter procedures. The tricuspid valve has been called the forgotten valve because treating it surgically is so complex. But if left unaddressed, severe tricuspid regurgitation can lead to right heart strain and poor life expectancy. We're now using investigational clipping devices to intervene sooner. For example, the TriClip grasps the edges of the tricuspid leaflets, reducing regurgitation. Transcatheter tricuspid valve replacements are also on the horizon and are still being evaluated in clinical trials. Next up is left atrial appendage closure. In atrial fibrillation, blood can pool in the heart's left atrial appendage, forming clots that can travel to the brain, causing a stroke. If blood thinners aren't an option, we can close off the appendage permanently. A device like the Watchman is delivered through a catheter into the appendage. It acts as a barrier to keep clots from exiting that area and moving to the brain. Patients can stop taking warfarin after implantation. And last but not least, we will briefly cover amplats or septal occluders for A.S.D or atrial septal defect. Structural heart defects are holes or abnormal openings between chambers of the heart present at birth. One of the most common is a hole between the upper chambers called A.S.D. In the past, repairing defects like these required open heart surgery. But now, doctors can use a minimally invasive approach with the septal occluder, a small mesh device that covers the hole through a catheter inserted in the leg. Let's talk about how it works. First, a catheter is inserted into a vein in the groin and threaded up to the heart. Once the catheter reaches the defect, the occluder is passed through the hole. One side of the disc-shaped device opens up on the left side of the septum or wall between chambers. Next, the right side disc opens against the other side of the septum, sandwiching the defect. When positioning is confirmed, the device detaches from the catheter and gets embedded into the heart tissue, permanently closing the hole. Over time, heart tissue grows into the mesh, integrating it into the septum. This repairs the defect without major surgery, just a needle stick in the leg. Patients usually stay in the hospital overnight for monitoring and can return to normal activity within a day or two. The occluder remains in the heart permanently. So, that covers today's topic on cardiac physiology. I hope this video gave you a helpful overview of this medical specialty and the role of cardiac physiologists. I plan to share more details about this allied health profession in upcoming videos. Don't forget to hit the like button and subscribe to the channel. Thanks for watching.